So for those of you who haven't met Dr. Sekabira, he's the head of the pediatric surgery unit in Kampala, Uganda, at Mulago Hospital, which is affiliated with Makerere University College of Health Sciences. He trained in medicine and in surgery at Makerere. He then trained for pediatric surgery in Durban, South Africa, under the mentorship of Larry Hadley, before coming back to Uganda, where he's really done an incredible and amazing job building up this unit, developing young people, developing and expanding the scope of services provided, and expanding children's surgery across Uganda and the region. He's held almost every leadership position really in the hospital. And I think he's taken on a new one lately as the deputy executive director of the hospital, but he's led the country's professional surgical association and had many leading roles. When we first started working together closely, he was really the only active pediatric surgeon, if you can imagine, for the country. This is really in the time around 2010, 2012. And to go from that to where we are now is a journey that really only he can tell. And I'm just so proud to have been a small ally in that journey. So I'm just going to hand this over to John to speak with us today and share his experiences.
Thank you, Doru. I don't think I deserved all those pleasantries. Thank you. Okay, as you have heard, I think my screen is visible.
Yeah, we can see it.
Yes, Dr. John Sekabira from Uganda, no disclosure. For those of you who haven't been to Africa, Uganda is just a small dot, maybe in the East Central Africa, but more to the East Africa. And it is subdivided into governing districts and regions. And most of these regions, as you see them in the darker color, each one has a regional hospital where you can find surgeons. Maybe some facts about Uganda. As of January 2016, that's when the last population census was done. We had a population of 39 million, almost 40 millions. And the population growth rate is incredible, 3.26 per annum. And the population below 15 years is 52%. And life expectancy was then, but now it has hit 60 years as of now. We have a high fertility rate, so it means we have so many babies born each year. And that does not actually emphasize the fact that it's not surprising that we have so many congenital abnormalities. Mortality rate is still high in the rest of low-income countries. We have a neonatal mortality rate of 27 per 1,000 live birth, and infant mortality rate is even when that one cumulatively is bigger. If you can imagine the population pyramid, if you compare it with that one of US, you find that most of our population is young. Actually, as I said, most of the population is below 50 years. And if you take if you say from up to 50 years, you think it is more than half of the population. And when you compare that one with US, it's incredibly different. So that's why you find a very young population. And that means pediatric surgeons have a lot of work to do. I just put a snapshot of that is the old nursery where we have so many babies crammed together in small cots. And all those ones, some of them have congenital abnormalities, surgical conditions, which sometimes go unrecognized. About development, is ranked 161 out of the 187 countries according to 2013 Health Development Index. So it's low down there. And the total expenditure per capita, despite that abysmal figures, we have very little expenditure on health, I think $108 per capita. And total expenditure on health is just 8.9%. And most of this money goes into administration, unfortunately. As I mentioned earlier, we have Health Center 3, Health Center 4, and district hospitals, and we have so many PNFPs, that is missionary hospitals, which offer, we have surgeries which can happen at district hospitals. But Health Center 4, sometimes, most of the time, you have maybe simple hernias, but not for children. So children surgery safely can be done at regional referral hospitals, and we have only 10 in the country, and the majority of the conditions have to be sent to Mulago. As I said, we can only find specialists in the regional referral hospitals, and Mulago is the only tertiary hospital for the country, and we don't have a pediatric hospital. And that is a picture from Mulago Hospital. The pediatric surgery unit is now located on the level 5, and we have the pediatric, now it is bigger, we have the pediatric critical care, we have neonatology, and this one pediatric surgery. So pediatric surgery now occupies 2 wings. One pediatric surgery has 2 wings with the general pediatric surgery and urology, which is around 20 beds. And but I have to tell you that I think the bed occupancy can sometimes go even to 100%. So you can sometimes find 40 children because we put so many beds in between, though sometimes this is not encouraged. And the neonatal wing, which we are now developing, we want to develop it into like a high dependency unit for neonates, which has 16 beds. And luckily enough, now we have, after the renovation, we have adjacent PICU, which is not yet functional with the 8 beds. But I think if we functionalize it, it's going to change the outcome for children's surgery in the country. Currently, we have 6 pediatric surgeons, 3 fellows, 2 residents, and usually we have intern doctors and a few nurses. We think that if we advocate for creation of a neonatal wing, we are advocating to get more nurses so that we can beef up the number of nurses. We have 12, very few. And we run the clinic, which currently runs on 1 day, but we think it should divide it now because as we are becoming a bigger group of pediatric surgeons, because as I plan to show that picture, we get so many patients crammed together. And if you are you to be alone to solve those patients, it can be incredibly tiring. So we intend to divide it to the clinic so that we have like 3 clinics running in a week. That is now in the renovated Mulago. Maybe the challenges to pediatric surgery in Uganda are universally common to all low-income countries, are basically late presentation, poor transportation, lack of poor equipment and facilities, difficulty in anesthesia. I think this is very pertinent because sometimes we tend to think that we can do surgery, but when there is none good anesthesia, and especially for children, there is no surgery which can take place. And of course, shortage of manpower and heavy workload. And another thing is lack of research and publications and awareness. So late presentation, this one usually affects all aspects of pediatric surgery. A study which we did not long ago showed that on average, even children with babies with the intestinal atresia, which usually, as you know, the presentation sometimes is obvious, a baby has bilious vomiting, but takes 8 days on average for them to reach our unit. Even incredibly that babies with gastroschisis, which have an obvious lesion, take 3.5 days. That is from our database. So we find that we need to address this issue of late presentation because you can imagine a baby with gastroschisis arriving or 4 days later after birth, there's nothing much you can do. And most of the neonates with surgical emergencies, 90%, are born at home or regional or rural hospitals, and sometimes by traditional birth attendants. So they have no clue on whatever is happening. So by the time they reached us, they have already been compromised. Their physiology has changed, and there's nothing much you can do. And there is a tendency of sometimes parents seeking alternative care before they come to us. I just put a picture of, this is, I think, Doruk can bear testimony, because we have these baby children with huge tumors. And most of them, when you look at their bellies, some of traditional healers have put scratches on their abdomen, which means that they've been trying to seek alternative treatment. So they come late with already metastases all over the place. They are malnourished and sometimes with hypertension. So it becomes very difficult to start even thinking of treating such children. I don't know how in the US, where you do primary section of, for example, Williams tumor, what will you do for such a patient? Because there is no way such a patient can withstand any surgical procedure. Another issue is our poor transportation. As you know, there is an elaborate system of, for example, transportation of neonates in high-income countries, but in our country, the referral systems are poor, and most of the parents become their babies by themselves, sometimes on motorcycles, without any referral note, and first go from one hospital to another. And ambulance service is almost non-existent, and most of the patients, as I mentioned, they come with private means. And most of the neonates, because, as I said, they are born in regional rural hospitals, sometimes with TBAs, nobody takes care of stabilization before even bringing the babies. And of course, like, you can't imagine on providing warmth or even on oxygen on a motorbike, which we call borders, which sometimes bring these babies, and they come already with physiological derangements. About poor equipment and facilities, I just put this picture. I think Doruk remembers this baby very well. Like, we used to have, this is the NACOMED, I think, model 1980s, which some was still working in a ventilator. We used to do esophageal atresia, and you hook this baby on a ventilator, and you could not a ventilator of an anesthetic machine, and you bring the anesthetic machine from theater, from OR, and you maintain these babies. But at one time on such an adventure, of course, the ventilator stopped in the middle of the night, and people had to ventilate the babies throughout the night. So these are the things which we are trying to change, so that the outcome of neonatal surgery changes. As I mentioned, the difficulty in anesthesia. Anesthesia impacts a lot on the outcome of surgery, as you all know. We have only 3 pediatric anesthesiologists for the whole country, and very few anesthetists are interested in pediatric anesthesia. Majority of them, even by mention of that you are bringing a baby to theater, they run away, they don't want to touch that baby. So you find that most of these babies are done in rural hospitals without proper anesthesia care. And as as you all know, most of the anesthesia in the country are provided by anesthesia clinical officers. And sometimes we lack modern anesthetic drugs. I think most of the maybe residents in anesthesia from high-income countries have never seen a bottle of halothane in their practice, but this is sometimes the only alternative drug we have for pediatric anesthesia, and a few intravenous anesthetic agents. So sometimes this can change the outcome of such babies. It's only in the bigger hospitals like national referral hospitals where you have modern anesthetic drugs. even to sevoflurane, but in the upcountry hospitals, we don't have, there is no luxury of having those anesthetic agents. So coupled with available suboptimal equipment and poor anesthetic drugs, this can lead to turbulent general anesthesia, which can result in poor outcome. Of course, the shortage of manpower is evident. We have only 7 pediatric surgeons with a population of 38 children. That's children below 18 years, which are, for example, if you take half of the population, we have like maybe almost 20 million children who might require surgical treatment, and with only 7 pediatric surgeons. That's why you find most of the surgeries are performed by general surgeons. And of course, the outcome might not be as good if the surgery was done by pediatric surgeons. As you know, in Europe, we have 1 pediatric surgeon for every 400 patients. But in Uganda, I think we are very far reaching that. And it is worse for neonatal emergencies, other outcomes are poor. And of course, the outcome of surgeries can be poor. Just put this picture to show what is recommended by WHO, but rather by APSA, American Pediatric Surgical Association. If we recommend 1 surgeon for 100 pediatrics, rather 100 children, Uganda, where we are with a population of 20 million, would need 200 pediatric surgeons, and we have only 194. So rather we have a deficit of 194 pediatric surgeons. But of course, the picture is not different in all other countries, surrounding countries. Maybe Kenya, I see Dr. Zipu is here. Zipu is here, maybe can tell us how the picture is in Kenya. But countries like Rwanda, until just of recent, they still had 1 pediatric surgeon. And if you compare in US, for US, they have even an excess of 640. Maybe some of them might be rendered redundant. They need to come to Uganda, or maybe to Africa and practice pediatric surgery. I just put a picture of some of the graduates under COSEXA who just finished. That was a graduation 2016 in Mombasa, where they graduated the first pediatric surgeon for Rwanda, and of course he's standing with a pediatric surgeon, and 1 for Mozambique, the first one also, who graduated that year. So in the entire all low-income countries, and especially Africa, the requirement for pediatric surgeons is enormous. And of course, this does not only stop on pediatric surgery, on pediatric surgeons. The shortage of all non-relevant staff trained in care for children. For example, we don't have any pediatric radiologists, and all the investigations are done by general radiologists who sometimes don't put, they can lack the skill to make a proper diagnosis. As you know, for example, if you want to do distal colostogram, you need a specialist radiologist who can understand, probably you need high pressure contrast to be pushed in the distal rectum so that you can demonstrate the fistula and even to know the distal extent. But sometimes this is not possible, and we bear with it. Sometimes you go and discuss together, and most of the time their reports are not reliable. And as I said, most of the ultrasound scans in rural hospitals are banned by technicians, and sometimes they're only interested in giving the sex of the babies, and some of the congenital abnormalities are missed. Even, for example, glaring, like anterior abdominal defects, they can be missed. And no pediatric pathologists, and sometimes making mistakes, for example, like making diagnosis of Hirschsprung's can be problematic. So most of the time we rely on clinical presentation, and what happens, we don't rely on pathology most of the time to make a diagnosis, even to find where you resect the bowel for pull through. We rely on the bowel where you have placed the colostomy. If it works, then you know there are ganglia there without relying on histology. And of course, the heavy workload is obvious. And people, the surgeons, when they are working long hours with poor facilities and the poor equipment, and of course with the low pay, most of the time can lead to burnout. The issue of publications, much as we are crying, most of the countries, we don't have data to support our advocacy because there is little publications out there to lead to influence a policy so that more resources can be allocated to pediatric surgery, because the awareness is lacking. And sometimes even clinicians, sometimes doctors can ask you, really, do children also have, for example, cancers or any other thing? And so awareness is still poor. And this, of course, as I said, is poor allocation of resources, even from the politicians, because they are ignorant about what is happening. And how do we try to mitigate, to see to it that we improve the outcome? With the help of colleagues, especially I would love to upload Doruk and other faculty, international faculty, we started the COSEXA training program, because by then there is a time when I was alone, but we had 2 other surgeons, one of them had retired, so which constituted the faculty. So, but by then to be accredited, we had to show that we have international faculty, which come to help us. And in a space of 6 years, we have managed to train 5 pediatric surgeons, and we have 5 fellows currently undergoing into training through COSEXA. But I have to say that some of these surgeons have been having stints, rotations outside the country, and where they gain experience, especially in minimum access surgery and high-end care, for example, critical care, which is not sometimes available in the country. And as I said, we are starting soon a pediatric anesthesia training program under CANEXA, that is an arm of anesthesia under COSEXA, which is soon going to alleviate that issue of provision of anesthesia for children. And there is the hospital in Entebbe, that is in another town, and where the airport is. We have a hospital, like an NGO hospital called the Emergency. That is an Italian NGO, which has promised to train for critical care nurses. And okay, they don't promise only to train critical care nurses, but of course also OT nurses and the other cadres, even biomedical engineers. And we are working on memorandum of understanding. And I think this is also going to help us in address some of the challenges we face. I want maybe to show you a picture. This slide shows you a picture of some of the people who have undergone training. We have, okay, Sister Maseng, I don't know whether you are seeing my cursor, is from Tanzania. She went back, and this is Anna, Dr. Nwesonga, and Dr. Arlene Muzira. By then, this picture, they were in Vancouver, UBC, in furthering their training. And we have Dr. Innocent Okero, currently is in Edmonton, with Dr. Sly is undergoing further training in minimum access surgery, and Dr. Felix is soon completing, and Dr. Stella Nemanya, the one lifting a baby, just completed pediatric surgery training fellowship. She's a newly graduated pediatric surgeon. I want this slide to try to show some of the visiting faculty we have had over the years. It's not exhaustive, because Dr. Doruk should be up there, but of course there are so many others. Just this one will show you some of them who have been visiting us to train us. I want to show, for example, Dr. Tamara Fitzgerald from Duke. She has been coming to Uganda almost like twice a year. Dr. Monica Langa has been part of our training program, and others who have participated, we really owe them a lot for having helped us in the training. Professor Geoffrey Blair, Dr. Prof. Jaden Nectan from Baylor, and all the others, Professor Brian Cameron from McMaster, and all over the place from Dr. Mera from Cincinnati. And of course, as I said, this is not exhaustive. These have done a tremendous job in the training, and also they participate in the provision of care for example, even surgical camps. And when they come, they bring a lot of items which might be lacking, like for example, sutures and most of stuff. Actually, when they are coming, they come with suitcase loads of equipment and stuff, which pushes us a long way, almost finishing us, taking us a whole year without requiring anything from the meager resources we have in the hospital. About improvement of infrastructure, we have currently renovated Mulago Hospital, which has actually changed the outcome of especially our neonates. For example, from the data which we have so far collected, out of the gastroschisis, now our outcome has improved. It almost survival is hitting 60% because of the better facilities we have. And of course, there are so many other variables which have improved. But of course, the facilities, improvement of facilities changes a lot about the outcome. And Kids OR, as you know, it started from Uganda. It started as Arch Foundation. They first kitted one theater in one hospital during the renovation of Mulago, that is Naguru Hospital. And from then, I would like to thank Ava Yap. Her tremendous work showed the world that this theater can change. A few dollars invested in the construction of this theater has managed to save so many babies. So from that data, they managed to roll out so many theaters, with kitted for us more theaters, 3 pediatric theaters in the renovated Mulago. And now currently we have 3 theaters to ourselves. But of course, we share them with the neurosurgery, pediatric ENT. And so this one has done a lot in changing the outcome of children in the country. And as you know, now they have kitted 50 theaters, mainly from high-income countries. So we thank Kids OR for these efforts they have done, which has changed the outlook of pediatric surgery in the world, mainly from low-income countries. This is like a picture of one of our theaters in the Mulago. As you can see, the logo of Kids OR is very prominent, and they provided, of course, the operating lights were there, but most of the equipment, anesthesia, warmers, and everything, which, as you know, can have a very big impact on the surgery for children. And this is the operating theater. And of course, so many instruments which were provided by the Kids OR. This is the recovery room, which is with all the, I didn't show you the monitors. This is the time when we are kitting it, but it's very well equipped with all the monitors for care of the postoperative babies. And about research, we have maintained, actually, thanks to Doruk, because he's the one who intrigued us to start collecting data. That is way back in 2012. And now almost 20 years, and we have one of the biggest prospective database in Africa. And a lot of papers have been churned out from this database. And I think more than 20 is just an understatement. We have, I think there are more than 20 publications which have come out of this database. And now, with the help of Kids OR, I want to widen the scope of data being collected. Maybe to show that our care has markedly improved, I want to share with you our experience in separation of conjoined twins, which of late has become like a routine because we are getting so many, an avalanche of conjoined twins coming to our center. As you know, separation of conjoined twins is one of the most fascinating situations any pediatric surgeon can face. And there is always anxiety and there is a lot of media attention about surgery for conjoined twins and also associated abnormalities, which you can find, which can also be like conjoined twins. And it's always exciting, but always risky, and it requires proper planning, which can involve a lot of disciplines during the planning. But it is better you avoid the media and publicity during this planning, because we always try to avoid the media when we get this baby so that nothing is known in the media. Otherwise, once you start publishing what you have, also making it known, it can create a lot of anxiety and even can compromise what you are planning to do. I just wanted to start by, this was way back like 6 years ago. We had previously received the twins whom we are not almost couldn't offer care, but the first twins we received were like 6 years ago, where I would name them Kabali twins, but we managed to like fatten them up, feed them, but we couldn't separate them by then because we didn't have facilities. We contacted our colleagues. I don't know whether you remember, any of you remember Professor Al Hamza, who was in Egypt, Cairo, Egypt, and he offered to take these children to Cairo and offered also, I tried to accompany them. And this one helped me like to gain what I can say, like develop thick skin to see that you can develop actually this surgery is possible. Right now, after separation, this is now at 6 years. They are grown up boys. One of them, of course, as you can see, the one on the left of the screen has some scoliosis. But we are following them up. They are growing well and they are going to school. So then we had another set, though this was the picture is not very clear. I tried to look up the pictures. These twins came to us and they had the lower anorectal malformations. So we had, by emergency, we had to put colostomies. That was back then when we didn't have proper theater facilities, better theater facilities. We could only offer them a colostomy, but that one saved their lives. But later on, they went to Columbus and they had the separation from there and they came back. We are also following them up. They are growing up very well. But there are other conditions which can really be fascinating. Like, I don't know whether you can see this picture. This baby was born, the press put it like 8 legs. So we had to do this surgery, and this one went all the way after separation, after removing this like a parasitic twin, and it hit headlines in the local newspapers. And also we received the other parasitic twins. This one, the one which is joined also on the chest abdomen. We removed it, and also the baby survived and is doing well. Of course, we get other conditions like this one, fetus in fetu. This is like a baby, you can see structures, sometimes maybe like a brain. This can have a brain, liver tissue, intestines, and all this one. And this one presented almost the baby was exsanguinating because bled a lot. We had to do a lot of resuscitation and came all the way from up country, reached the place when almost was paper white, but managed to save the baby and now is doing well. Of course, there are twins which are inseparable, like this one was from Iganga. They came to us, Iganga, another town, in another region east of Uganda. They came to us, but of course, after separation, after investigation, we found that they are inseparable. The hearts were almost, they were sharing the ventricles of the heart. We couldn't offer any surgical treatment. We thought even if they went outside the country, they couldn't be separated. Of course, they succumbed along the way. The mother refused to stay in the hospital and still lacked oxygen. Because of poverty, they went away. But of course, they came back rushing, but we could not do any resuscitation and the babies died. Some of the successes we have had, one of this one, as you know, as you see, the ischio pega conjoint twins. This picture, we took it when we are going to place tissue expanders so that we could be able to get enough skin to cover the defect after their separation. This one was the first major set of conjoint twins we separated after the renovation of Mulago and even acquiring better equipment and facilities. As you can see now, you can see a mold of the tissue expander on this slide. And by then we have achieved enough skin to cover the defect after the separation. And of course, this involved a lot of planning. We had to do a lot of imaging, distal abstraction to demonstrate the skeletal tissues, the soft tissues, the vessels. We had to do CT and MRI angiograms so that we planned properly and see how they could be separated safely. And this involved, of course, radiologists, neurosurgeons, cardiothoracic, other vascular surgeons, and orthopedic surgeons, because by the time we separated them, the bone structures were already very solid and it took us a lot of time to do this surgery. From these are planning images, you could see even the spine cord is like almost fusing here in the midline. And of course, this took a lot of planning, and we had to start planning